Good afternoon or good morning to you, depending on where you are. My name is Jose Leon. I am the Chief Medical Officer for the National Center for Health and Public Housing. Thank you so much for joining us today to discuss this learning collaborative, expanding diabetes prevention and management through health center outreach. In addition to being the Chief Medical Officer for the National Center for Health and Public Housing, I am with the American Diabetes Association, as I'm part of the Primary Care Advisory Group, as well as the Professional Practice Committee, reviewing diabetes content on anything that is related to emerging issues or topics. So this is a very good opportunity for me to learn from you as well on your needs and anything that you would like to bring up during the discussion. So this is honestly a very good opportunity to exchange and information, feedback. We are learning together, and it's such a great honor to be leading this conversation. Before we get started, I have some housekeeping items. At this moment, all participants are muted. If you have cameras or you would like to turn your camera on, that would be great, just to make sure that everybody knows each other. We are asking you to please engage in chat. Again, this is a great opportunity to discuss, to exchange information, best practices, challenges, whatever you would like to discuss. This is a great opportunity. This is a small group, so I encourage you to participate and provide feedback and information on best practices and challenges or recommendations that you have for other health centers. At this moment, this session is being recorded, and the slides and the recording will be sent to you via email within a week after the session. If you have access to Moodle, I'm not sure how many of you have access to Moodle, but if you go to moodle.nchphc.org, you will be able to find information, resources, or the welcome packet, and everything that is related to this learning collaborative. In order to do that, you need to create an account, and then there will be some detailed and very easy instructions on how to access the materials. The National Center for Health and Public Housing is supported by HRSA to provide training and technical assistance to federal qualified health centers. We have expertise in providing training and technical assistance to health centers located in or immediately accessible to public housing. And before we get started, I would like to hear from the participants. As we have a chat either through the chat, or if you would like to unmute your line and get your name, your role, the health center or the organization that you work for, and the location and the number of clinical sites. So if any of you would like to either type that information on the chat, or if you would like to unmute your line, this is the opportunity to do so.
Dr. Leon, I just like to mention right now that there is a little bit of background noise, so I just wanted to make sure that your lines are muted for now, and then later time.
Do you want me to mute my line?
No, some of the other participants that have.
Got it.
Yeah.
Perfect. So is there anyone feel sharing information? Sorry.
Yeah, we have somebody from her name is Paula Hubbard, and she is a current student in public health. And she said that she's currently finishing serving in South Dakota at the Cheyenne River Health Center. We also have somebody who is a lead nutritionist. Her name is Biliana Watts, McGilvery. And we also have other participants from health centers, for example, Franklin Primary Health Center. Thank you so much for joining.
Thank you so much for joining us. Thank you so much for sharing your location, your name, and your title. Again, we are going to discuss a couple of things today. So this is the agenda. We are going to review the definition of diabetes and prediabetes. We have a case study to discuss, and we're going to explore some diabetes resources. And then we will have a question and answer session just after this presentation. As a very quick overview, there are 107 health centers, well, 108, according to the 2019 HRSA data, UDS report, public housing primary care grantees. And in 2019, they provided services to over 800,000 patients. The same report have 433 FQHCs located in or immediately accessible to public housing, and in 2019 they provided health care and preventive services to over 5 million patients. If we move on, we have the public housing demographics. This is extremely important because we can see all the clinical aspect of diabetes, but sometimes we tend to forget some of the social determinants of health or history, medical history of our patients, which is really important when we discuss chronic conditions such as diabetes or cardiovascular diseases like hypertension or any other chronic condition. So this one of the main highlights here that I would like to mention is that in public housing, 43% of those living in public housing are African American, and 25% of them are Hispanic. 35% of them are over the age of 65, and 38% of households reported that they have at least one person with disabilities. The other social determinants of health, which is extremely important to highlight when we discuss diabetes, is that 55% of those living in public housing have less than a high school diploma, which is quite important when you try to provide resources for your patients, such as and you need to also address the health literacy issues. So these are main social determinants of health that are important for patients with diabetes. Just keep in mind that diabetes is more prevalent amongst the racial and ethnic minorities, and those living in public housing are either African American or Hispanic. Also, when we age, we tend to produce less insulin or get overweight, and that's going to be going to predispose to diabetes as well. So the 2009, I mean the 2019 UDS report also mentioned that 9.6 of patients who were seen in any of the public housing primary care sites had diabetes. When you compare this percentage to the total population served by health centers, is a little bit higher. The total health center percentage is 9.08. So this is another reason why we need to discuss diabetes. This is a Diabetes 101, what you need to know, that has been developed by the American Diabetes Association, and it's a very good resource for CHWs and other medical professionals trying to get a little bit of more information about diabetes, specifically when it comes to diabetes prevention. they have some really good resources that we are going to discuss today. So the learning objectives for today's presentation are what is diabetes and prediabetes, why immediate care is required, basic components of diabetes care, and short and long-term consequences of diabetes. So this is a case study that we are going to discuss at the end of the presentation. JM is a 48-year-old Hispanic man who was seen in the primary care clinic for routine follow-up of hypertension, for which he had been treated for the past 8 years. His only medication was lisinopril, 20 milligrams per day. Home blood pressure monitoring averaged 128/82. He had a family history for hypertension, type 2 diabetes, and coronary artery disease. JM reported a 20-pound weight gain over the past year, along with a sedentary lifestyle with no regular exercise routine. Other medical history was negative, including symptoms of fatigue, polyuria, or polydipsia, and he denied past or current tobacco use. So just keep in mind our Hispanic person who we are going to discuss later on. So this is for a live presentation. We usually ask the audience to raise their hand if you know someone with diabetes. And as we mentioned before, according to the latest CDC report, 1 in 11 Americans has diabetes. So that's the reason why HRSA has made this a priority. When we compare to the numbers that we just saw on the numbers provided in the UDS report, it's basically about the same. What the health centers are reporting probably is a little bit higher when you see the CDC numbers, but in any case, diabetes is a priority. It is a public health crisis. And all health centers are involved in developing strategies to decrease the A1C greater than 9 in patients with uncontrolled diabetes. So we also review the social determinants of health affecting public housing residents, and as I mentioned, those racial and ethnic minorities are more likely to develop diabetes or prediabetes. There have been studies, and for instance, American Indians and Alaska Natives are twice as likely to be diagnosed with diabetes. And in regards to Blacks, when you compare them to non-Hispanic, are more than 50% more likely to be diagnosed with diabetes. And compared to non-Hispanic whites, Asian Americans are 10% more likely to be diagnosed with diabetes. So based on the numbers and what we have just said, this is a very interesting number that every 21 seconds, someone in the US is diagnosed with diabetes. And diabetes kills more Americans every year than AIDS and breast cancer combined. We also need to keep in mind that this is not a disease that only affects the adult population. We also know that diabetes affects our children, and in nearly 2,000 American youth have diabetes, and 18,000 or nearly 18,000 are diagnosed with type 1 diabetes every year. With more than 5,000 new cases a year, type 2 diabetes is becoming more common in children. This is a big concern because it's based on studies. When a youth or when a child is diagnosed with type 2 diabetes, it seems that the disease is more aggressive than when you develop or when you have diabetes as an adult. In regards to cost, 1 in $7 healthcare dollars is spent on treating diabetes and its complications. So this is the reason why diabetes is so important and a priority for HRSA, as well as other chronic conditions such as cardiovascular diseases, kidney diseases, and the colorectal cancer screening or cervical cancer screening. So, Fida, I'm going to stop for a moment and see whether there is any comment or anything in the chat.
We don't have any comments.
Okay, thank you. So what is prediabetes and diabetes? This is our first learning objective. Prediabetes is when your blood sugar levels are higher than normal, but aren't high enough to be diabetes. And we are going to take a look at the numbers. One of the things to mention here is that when you have prediabetes, you have no symptoms. You have, your sugar is high, but it's not high enough to develop any symptoms. So this is a condition that we need to make sure that we address every time that we have a new patient in our clinics. And the report, the CDC report, is that 84 million American adults have prediabetes, and 90% of Americans with prediabetes don't know they have it. So again, to summarize, is when prediabetes, when you have your sugar levels higher than normal, but not so high to be diagnosed as a diabetic patient. And this is a condition when you have no symptoms and is very frequent or prevalent in the US population, just to keep those numbers in mind. Now, sorry. Diabetes can lead to diabetes or type 2 diabetes and many of the serious complications. So there is a resource that we can use when you have a patient that may be at risk, is on the diabetes.org website, and is the risk test. And I'm going to stop for a moment just to show the resource. Fida, just let me know if you can see my screen right now.
Yep, I can see your screen.
Okay. So if you go to the American Diabetes Association page, you can go to the take charge and see for yourself.
Sorry, Dr. Noon, I apologize. You may have to reshare the screen. I can only see the one that has the slides on it.
All right. So let me share it with you. Let me see, share. Now I believe that you can see it, right?
Yes.
Okay, I'm sorry. So if you move down, you can take the risk test, or you can invite a patient to do the risk test, and let's do it for someone else. Let's do it for a patient. Our patient is between the 40 and 40 years, between 40 and 40 years. Is a man. He has a family history of diabetes. The patient has high blood pressure. The patient mentioned that he is not physically active and is a Hispanic patient. Even though we don't have this, probably, let's say that is 5'7", and the patient who was a little bit overweight, let's say that he is between the 159 and 190 pounds. And then you have the option to either email the results or view the results online. So as you can see, our patient is a high-risk patient. He's a high risk for developing or type 2 diabetes. And this is a patient that if you are in the community, you have to basically invite the patient to go to any of your clinics and be and get tested, just for any of the available tests. We can say whether the patient is either pre-diabetic or diabetic, but this resource is very useful for patients and for community educators, CHWs, and nutritionists, just to go to the American Diabetes Association and invite the patient to take the test. So let me go back to my slides now.
Dr. Leon, in the meantime, while you were discussing about the percentage about the on diabetes, the Lakota, somebody commented saying the Lakota does have a greater percentage of diabetes from what I experienced in the laboratory. And she also asked, asked the question, would prediabetes be an A1C over 6.0?
And that's a great question. And we are about to address the levels. This is, again, the American Diabetes Association number. So as we continue the presentation, we are going to review, what is the standard for prediabetes and diabetes. But thank you for the question. That's great. Thank you. So now that we have discussed diabetes, we are moving to diabetes. And diabetes is when a patient has the blood sugar levels higher than normal. There are 3 types of diabetes: type 1 diabetes, type 2 diabetes, and gestational diabetes. Now, this is for our education regarding nutrition. How is food related to diabetes? So the body breaks down food into glucose and sends it to the blood. And the insulin produced by the pancreas helps move glucose from the blood into your cells. The glucose moving to your cells is either used as fuel for energy or a store for later use. So if you have diabetes, there is a problem with insulin, but not everyone has the same problem. So what are the symptoms of diabetes? Symptoms include urinating often, feeling very thirsty, and feeling very hungry, even though patients are eating. These are the main 3 symptoms. Then there are others like extreme fatigue, blurry vision, cut, bruises that are slow to heal, weight loss, and tingling pain or numbness in the hands and feet, especially when you develop a neuropathy or any other diabetes complication. So we mentioned that there are 3 types of diabetes. Type 1 diabetes is when your immune system mistakenly destroys the beta cells in the pancreas, and these are the cells that produce that make insulin. This is more frequent in children, even though, as we mentioned now, children are developing more frequently type 2 diabetes as well. What causes type 1 diabetes? Well, scientists and researchers are unsure what causes type 1 diabetes. What we know is that this is not an infectious disease, it's like a chronic condition, and it's not contagious. And there are research studies underway to find exact causes of type 1 diabetes and how we can prevent type 1 diabetes. In regards to type 2 diabetes, this is when your body doesn't use insulin properly, and this is called insulin resistance. So what puts you at risk for type 2 diabetes? There are some risk factors: history of high blood glucose, prediabetes, or gestational diabetes. When the patient is overweight or obese, when there is some physical inactivity, family history, genetics, race and ethnicity, age, when there are cardiovascular diseases, high blood pressure, and cholesterol issues as well. So this is to respond to the question that we had. For the American Diabetes Association, when the A1C is between 5.7 and 6.5, that is considered prediabetes. Any number over the 6.5% is considered diabetes. If we have the fasting plasma glucose, those numbers are, if you are lower than the level, if the result is lower than 100, that's normal. If it is between 100 to 130, 25 milligrams per deciliter, that is considered diabetes, and anything above is considered diabetes. And the same for the oral glucose tolerance test. If the result is less than 140 milligrams per deciliter, that's normal. And if between 120 and less than 200, that's considered prediabetes. And over 200 milligrams per deciliter, that's diabetes. Remember that diabetes, or I'm sorry, that prediabetes, I mean, when someone has prediabetes, the patient has no symptoms, so you can see those elevated results, you know, and you ask the patient will basically say that the patient has symptoms. I'm sorry, the patient doesn't have any symptoms. So the last type of diabetes is the gestational diabetes. And this one develops during pregnancy. If the patient's glucose level return to normal after giving birth, then the patient is a higher risk for developing type 2. And if the blood glucose doesn't return to normal, then the patient will be diagnosed with type 2 diabetes. So how is diabetes treated? We have meal planning, exercise, we have oral medication, insulin, and other injectables. But when patients are not taking care of themselves, or the patients have diabetes or uncontrolled diabetes, the patients can develop a nerve damage, kidney damage, eye problems, amputation, and heart disease and stroke. So what can you do if you have prediabetes or diabetes? These are recommendations for the patients. The patient, we can advise the patient to to lose weight if needed, increase their physical activity. The patient needs to follow a meal plan and take the medications. And this is a very important issue. The medication, for different reasons, sometimes patients do not take medications properly. We have many issues regarding medications. Again, if you are working with low-income populations, I mean, they have to juggle with different needs, and sometimes they have to choose food over insulin or any other priority, and sometimes they can't afford the medication. The other one is medication adherence. Patients either forget to take the medication, or they have other social issues, and we need to make sure that we also address those issues when we are with our patients. So we mentioned that the patient needs to be physically active. When the patient is more physically active, the body is more sensitive to insulin, and so the insulin can work better. The cells or the tissues or the organs take glucose out of the blood during the exercise, and exercise improves the mood. And remember that some diabetic patients can also develop depression or anxiety, and this is a very good way to address those behavioral issues as well. So there are several types of activities that you can recommend to your patient: lifestyle activities, aerobic exercise, strength training, balance training, and flexibility training, or a mix, you know, and patients can try some of all of them. Based on conversations that I had with health centers in general, some of them have exercise lifestyle activities programs in place, and they offer exercise routines while the patient is also receiving nutrition education, or depending on where they are located, some of them go to, some of the health centers have outdoor activities, and they go to parks and exercise with patients and have different kind of activities just to increase the physical activity in some of these patients, which is essential to to deal or treat diabetes in addition to the medications. The other one is the meal planning. It's my understanding that we have a nutritionist with us. That's pretty good. And this is another resource taken from the American Diabetes Association in regards to the meal planning. This is, you can also go to another federal site or CDC to get this information, and you will find different pictures or materials showing how patients need to plan their portions and make sure that they are having not only they are not only addressing diabetes, but basically getting all the nutrients that we need, because even though we need to decrease the number of meals or food that can increase your diet, your sugar levels, we also need to make sure that the patients are receiving the proteins and the fat and the sugar that they need. This is not about eliminating sugar in the on the diet. That's not the purpose. If you have a diabetic patient and the patient is taking any of the medications for diabetes that is not having the enough carbohydrates, for instance, the patient can develop a very serious complication, hypoglycemia. So this is something that we need to work with the nutritionist, with the doctor, with the endocrinologist, and all of the team serving our patients. In regards to medications, we can have another session on this, but just to mention that there are pills, insulin, and other injected medications that can be used to treat patients with diabetes, depending on the severity of symptoms and the blood work results. So patient needs to have SMART goals. These have to be specific, measurable, attainable, realistic, and time specific. So this is an individualized plan that you need to develop with your patient. Not all patients are equal. Just make sure that whatever your role is, you are offering SMART goals to your patient, even if what you're doing is going to the community and offering resources or referring patients to the clinic. We are going to discuss in future presentation what the CHW role is when you have patients with diabetes, but the SMART goal is something that we need to keep in mind when we have a patient with diabetes and other chronic conditions. So for all of us, if we have a patient who is at risk of prediabetes, the American Diabetes Association recommendation is to take the risk test that I just showed. The patient needs to talk to the provider if they have prediabetes. If the patient has prediabetes, they can register for a local diabetes prevention program. There is a food hub as well on the American Diabetes Association. And if the patient needs additional resources, it's my own health centers in general offer excellent resources, but the American Diabetes Association also has the 1-800-diabetes number, where you can get additional resources for your patients. Now, if your patient has diabetes, they can register for living with the type 2 program, and they can register for the expert events, and register for diabetes self-management and education programs, visit the Diabetes Food Hub, and also call the 1-800-diabetes number. So before we go back to our case study, I am going to stop for a moment and see if we have any questions. If you would like to ask a question, you can be unmuted, or you can type your question on the chat box. Any questions, Fide?
Nope, not right now.
Okay. Let's go back to our case study, and I hope that we can really discuss this. Just to remind the case study, to bring the information back, JM is a 48-year-old Hispanic man who was seen in the primary care clinic for routine follow-up of hypertension, for which he had been treated for the past 8 years. His only medication was lisinopril, 20 milligrams a day. The home blood pressure monitoring averaged 128/82. He had a family history of hypertension, type 2 diabetes, and coronary artery disease. JM reported a 20-pound weight gain over the past year, along with a sedentary lifestyle with no regular exercise routine. Other medical history was negative, including symptoms of fatigue, polyuria, or polydipsia, and he denied past or current tobacco use. So JM presented with a waist size of 42 inches. His BMI was 34 kilograms over square meter, and blood pressure of 125/80. Subsequent lipoprotein profile demonstrated a common pattern associated with prediabetes, including a low DHL cholesterol and a high triglyceride level. The LDL was mildly elevated and total cholesterol was 199. His fasting glucose was 111 milligrams over deciliters, with a repeat value of 115 milligrams per deciliter over a week later. So questions, and let's have a quick discussion on this patient. From your standpoint, if you are a CHW, if you are a nutritionist, or if you have contact with your patient, if you are a nurse, what would you recommend to your patient to address his pre-diabetes and other chronic conditions? I'm sorry for the typo there. You can either ask to, I mean, you can speak verbally and you can online, unmute your line, or you can chime in and use the chat box, whatever works. Let us know. But it would be nice to hear from your experience. What would you recommend to this patient? What would you do with your patient from your professional standpoint?
Dr. Leon, we got a response, and
Okay.
Ronnie mentioned they would offer appointment with a center nutritionist.
Yeah, that's a great suggestion. The patient has a BMI, and the patient can be considered obese. And in addition to that, the patient is the waist size is 42 inches. So that's the one of the first things that we have to offer the patient. You know, the patient needs to be evaluated by a clinician and the nutritionist as well. That's great. Thank you so much for your input. Do we have anything else here?
Yep. So we have another response from Baliana. She says that she would encourage to come in for nutritional counseling as well, and follow up with a provider for possible med management. And we also have another response from Paula saying regular checkups and monitoring, improving eating habits.
Yep, thank you. And those are exactly some of the recommendations that we can provide to our patient, in addition to a couple of things that I believe that we can do. For instance, based on what we discussed, probably the patients, after being evaluated by a doctor, the patient needs to get in a physical activity program. So that's another thing that we have to consider. I am seeing that the chat is blinking out, and I can't read the comments. So is there any other comment?
Yeah. So we have another response also from Ronnie, saying that they would also encourage a dialogue with patients about what exercise he would like to try and set a goal, and follow up with patient weekly in regards to exercise log.
That's great, and that's a great idea as well. And one of the, I mean, this question is not listed here, but I would like to hear about from our audience whether they offer or what if they offer an exercise program or a food program to their patients, and or mixed, or what is the option for a pre-diabetic patient seen on any of the clinical sites of their health centers that they work with.
All right, and somebody mentioned they do not offer an exercise program, so, but they wish they did. Thank you so much for that response.
Thank you. And I'm not sure whether health center the participants are either offering prevention programs or whether they refer patients to a diabetes prevention program, which is another thing to do for patient with diabetes. Now, the other, we have already discussed some of the preventive services. The third question for our case study today is, what educational resources would you use and where you get the educational resources? We are interested in hearing for instance, whether the health center develops educational resources or whether they use any of the federal resources or the American Diabetes Association resources. So that's something that I would love to hear from the participants to see whether there is a need to develop additional educational resources for our patients.
So we just received a response from Beliana. And she says, my DSMES program, the American Diabetes Association, ADCES, and CDC.
Okay, great. Thank you. That's good to know. And it's not listed here either, but do you have or do you provide educational resources in other language than English? In public housing, for instance, we have Hispanic population. Some, if not most of them, sometimes they prefer to get services in Spanish, and I'm not sure whether you have educational resources in other languages, depending on where you are located and depending on the racial or ethnic minority that you serve.
Yeah, Ronnie and Beliana mentioned that yes, they do have Spanish resources.
Excellent. So this is really important. It's extremely important to provide these kind of resources to our patient. We also mentioned the health literacy issue that we've been discussing with other groups. I am part of the National Training and Technical Assistance Diabetes Work Group, and educational resources and health literacy are really important when you have patients with diabetes, and just making sure that the resources that you are providing to the patients are easy and simple to understand. So there are several resources as well where you can see whether or not these are the type of resources that you can offer to your patients. Any other comments, Piri?
Yeah, we did have another response in regards to the types of educational resources. This was a feedback from Paula saying that she's not familiar with the resource during COVID. Most of it was closed down and it's still closed in Cheyenne River Health Center. And we have another response from Paula also. This is in regards to the other bilingual resources. She mentioned that she doesn't have that information. It might be available in Lakota, but not in Spanish here, as there is not a need for that language on the reservation.
Excellent. Thank you so much for sharing that information. It's very useful. And again, it will depend on where geographically you are located. That's not probably a need in some states. It is a need on other states, like people serving patients in urban areas and like large urban areas like New York, for instance, or Los Angeles, California, San Diego, California. We have some health centers located in those areas, very close to the border as well, who may need these kind of resources. And in regards to COVID, that's another great point. You know, COVID has basically changed the way that we are serving patients, and we are one of the sessions that we are going to include is where we are moving now to offering virtual visits and the role that not only clinicians but staff, clinical staff will have when addressing diabetes virtually. Now we are using telemedicine and through telemedicine we have different platforms, different apps to communicate with patients. So COVID has basically changed the way that we are offering services to our patients, and it will also change the educational resources that we have to offer to our patients, or at least how to make sure that they get the educational resources. We are moving from probably printed copies that we'll usually give to patients to electronic copies or websites where patients can access information on diabetes. So to summarize a couple of things that we have discussed, some of the items, the role of CHWs in diabetes prevention, we have three pillars. One is strengthen connections and health centers and the community. So it's a link between the patients and the community and the needs, and knowing the social determinants of health affecting our populations. There are things very important to discuss, such as smoking cessation services, you know, and whether or not your health center offers smoking cessation services. Patients who smoke are more likely to develop diabetes complications. Is looking at housing, which is another big issue that we mentioned when patients have to decide whether they get medication or they pay a rent or they have a place to live. We have public housing residents, we have people experiencing homelessness, we have migrant and agricultural workers as part of the special populations. So the CHWs are the core of professionals who are in touch with the community, and they know better than anybody the needs of the communities they live in. The other issue, the other role is they can offer also translation services, culturally appropriate materials. We've been discussing with some of the health centers located in large urban areas, as I mentioned, where they have people, not only Hispanic population, but people from Asia, from Africa, from other regions where they have the issue of communication. And sometimes patients cannot fully understand the instructions or recommendations that they get from the providers. So the CHW is another one who can help providers and the clinics in translation services, and offer also informal counseling, referral to the health center, referral to the diabetes prevention program. And so these are some of the roles. We are going to discuss these roles more deeply during our next sessions. But in general, these three columns have the information or have the skills that a CHW need to have on the services that they can provide to the community and to the patients, the pre-diabetic or diabetic patients. I would like to share some of the resources here. As I mentioned, we have the American Diabetes Association resources. You can access that. The website is www.diabetes.org. And then you can also get some resources from the Centers for Disease Control and Prevention, CDC website, or URLs www.cdc.gov/diabetes. And to access the American Diabetes Risk Calculator as well, you can go to the diabetes.org /risk calculator, and you can access the tool that we just discussed early during my presentation. So for our next session, we are going to have a discussion on CHWs and the evidence base for embracing CHWs into the public health and healthcare workforce, and specifically how CHW can help the clinic with providing some education or referrals to patients with diabetes. Our session will be on March the 29th, 1 p.m. same time through Zoom. This is the registration link. If you have any questions, you can contact the National Center for Health and Public Housing. That is my contact information, my email address. You can also contact any of the staff members and we will be happy to help you. I'm just going to stop one more time to see if we have any additional questions. Fide?
Yeah, so we had one last question from Paula, and this was in regards to the resources as well. We were discussing it. And it was mostly on, can the health centers request educational resources in different languages or translations from NCHPH?
We do not offer translation services, but that is something that we have gotten from a question that we have gotten from other health centers, and I've been recommending in other sessions to contact some of the embassies. They do provide translation services. These are organization licensed to offer those services. So if you are looking something in Spanish, for instance, and your population is from, let's say, Mexico or Guatemala, you can contact the Embassy of Mexico or Guatemala, and they will be able to translate and willing to translate those resources for you, and making sure that they are appropriate for your patients. I am a native Spanish speaker, and I can tell you that sometimes there are some differences between some countries and some words. Even though we speak the same language, the words are a bit different sometimes, and they can tailor the content of your resources to the population that you serve. So my recommendation is to reach out to the embassy depending on where the population that you serve is from, and making sure that you have an authorized organization providing the translation services.
Oh, interesting. Okay. Paula is mentioning, saying, okay, so we wanted something to distribute to the Mayan population for one of their dialects. Then we could contact them for that specific group. Thank you. Yeah.
Yeah, that's correct. You know, if I'm heard correctly, she's a Mayan population, Fide?
Yep. That's
so
correct.
we're talking about people living in Guatemala and the southern part of Mexico. And even though there are not too many people speaking the dialect, they do have resources in their country or in their country. So even if they cannot translate it by themselves, they can send it to the government of Mexico or Guatemala, and making sure that you receive those translations, and those are going to be official translations.
Mm-hmm. We don't have any additional comments right now, Dr. Neo, but I did wanted to clarify though that while you were reviewing the registration link, this is not a different registration link. It's the same one that you used to register for this session. So this same link that you used to join today, it is going to work for the next sessions as well. Just wanted to clarify that for everybody.
Thank you so much for that information, Fide. And again, in the meantime, if you have any other questions, just feel free to send me an email. That's my email address, jose.leon@namgt.com. You can also contact Fide, our health research assistant, fide@namgt.com, and we'll be happy to help you and to assist you with any other questions that you or comments that you have. Again, the slides and the recording will be on the NCHPH website, and then we are going to send the resources as well via email to all participants. So unless we have any other questions, Fide?
Yeah, we do have one last question from Beliana, saying, what is your view of LADA and MODY? I'm not sure what that stands for.
That's a question that probably we have to know the acronym. I'm sorry, I'm not familiar with the acronym. So if you spell it out, I don't want to say something that is not.
I think we could follow up via email.
Okay. All right. So in the meantime, that's something that we are going to reply via email to our participant. It's 2 o'clock. I would like to be very respectful of your time. Thank you for joining us. Again, if you have any